Welcome back to the deep dive. We're so glad you're here.
It's good to be back.
Today, we are taking a look at a system that, it really defines the rhythm of your life, from the very first breath you take to, well, to the very last.
We are talking about the lung.
We are. And it's a system that I think is deceptively simple. Most of us probably have this mental model of the lungs as just a pair of balloons, right? A pair of bellows in the chest.
Yeah, that's the common analogy. You pull the diaphragm down, air rushes in. You relax it, air rushes out.
Yeah.
Just a simple mechanical pump.
Exactly, the bellows model. It works for explaining the mechanics, I guess, but it completely misses the biology.
It ignores the danger.
Yeah.
I mean, completely. If you only see the lung as a pump, you miss the entire central tension of pulmonary pathology.
Which is?
The lung is the interface. It is this high-stakes, high-risk meeting point. It's the only place in your body where your sterile internal environment, your blood, is separated from the dirty, dusty, bacteria-filled outside world by a barrier that's, this is not an exaggeration, thinner than a single sheet of tissue paper.
That is a genuinely terrifying way to put it.
It should be, honestly. Every single breath is an exposure event. You are not just breathing in oxygen. You're breathing in nitrogen, yes, but also viruses, silica dust from a construction site down the road, car exhaust, fungal spores.
All of it going deep into the core of your body.
Exactly. So the biological engineering challenge here is just immense. The body has to solve this impossible problem. How do you create a surface area that's large enough, we're talking the size of a tennis court, to oxygenate 5 liters of blood every single minute?
While keeping that barrier thin enough for gas to diffuse across it almost instantly.
And at the same time, making it strong enough to stop you from dying of a routine infection or from all the toxins you inhale.
It sounds like an impossible triangle. You can't have all three of those things at once. Maximum surface area, minimum thickness, and maximum defense.
And that's exactly where disease happens. It's when that delicate balance breaks. So today, we're going to explore pulmonary pathology, not as a random list of diseases to memorize, but as failures of this very specific engineering challenge.
Failures of the barrier, failures of airflow, and failures of defense.
Precisely.
Okay, so to guide us through this pretty complex topic, we are, as always, pulling from two of the heavy hitters in the field. First, we have Robbins and Cotrane pathologic basis of disease.
The Bible, the absolute Bible for the molecular mechanisms, the cellular reactions, the how it all happens.
Robbins gives us that incredible granular detail, the cytokines, the genes. It provides that systems thinking framework that we need.
It does. And we're balancing that with Underwood's pathology.
Which is just fantastic for connecting that microscopic damage to the clinical picture. It really helps you understand why the patient with emphysema looks so different from the patient with fibrosis.
It grounds the pathology in the person. Now, a quick but very important disclaimer before we jump in.
Yes, this is crucial.
What we are doing here is an interpretive synthesis. We are building a conceptual map, a framework, to help you navigate these dense chapters. We absolutely cannot replace the fine print.
Not at all. Robbins has pages on specific genetic loci for lung cancer that we can't list them all in an audio format. It wouldn't make sense.
So please, use this discussion to scaffold your understanding, to get the big picture, but you still absolutely need to go and do the reading.
Think of this as the architectural blueprints. You still have to go lay the bricks yourself.
A perfect analogy.
Okay, so with that said, let's start with the system. If we're going to talk about how the lung fails, we have to understand how it's built to survive. We need to look at this, as you call it, architecture of survival.
Right. And to do that, we need to zoom in, way in, past the trachea, past the main bronchi, past where the cartilage rings stop. The real business of the lung, the gas exchange, happens at the functional unit, and we call this the acinus.
Okay, define that for us. What exactly is an acinus? Where does it begin?
It's everything distal to the terminal bronchiole. So once the purely conductive airways end, you get into the respiratory bronchioles, which have a few alveoli budding off them, then the alveolar ducts, and finally the alveolar sacs themselves. That whole functional unit is the acinus.
The gas exchange zone.
That's it. And Robbins then groups these together into a slightly larger structure called the lobule, right?
Correct. A pulmonary lobule is simply a cluster of, say, 3 to 5 of these acini, all wrapped together in a bit of fibrous tissue. The classic analogy is a cluster of grapes on a stem.
And that's an important concept because, as we'll see with emphysema, different diseases can attack different parts of that grape cluster. It's anatomically specific.
We'll get there. But for now, let's zoom in even further to the walls of these individual grapes, the alveoli. The cellular cast of characters here is incredibly specialized.
It is a very strict division of labor.
Hmm.
Let's start at the top, in the pipes, the airways leading down. The epithelium there is all about defense. It's mostly pseudostratified ciliated columnar cells.
That's a mouthful.
It is, but it describes their function perfectly. They're tall, columnar cells, and on their top surface, they have hundreds of these tiny, hair-like projections called cilia.
And these cilia beat in a coordinated wave.
A very coordinated rhythmic wave, always moving upward toward the mouth. This is the mucociliary escalator.
The trash removal system.
Exactly. It's constantly pushing this carpet of mucus up and out of the lungs. And that mucus is what traps all the inhaled dust, pollen, and bacteria.
And the mucus itself is made by the goblet cells, which are sort of interspersed among those ciliated cells.
Yeah, it's a self-cleaning conveyor belt. But there are other cells, too. You have club cells, these would be called Clara cells, which are really important. They secrete protective proteins that can neutralize airborne toxins.
Like a chemical defense shield.
A local one, yes. And even deeper in the lining, you have neuroendocrine cells. These are like little chemical sensors. They can release things like serotonin or bombacin to regulate the tone of the airways and blood vessels. It's a very active, very responsive environment.
But the real magic, and as you said, the real vulnerability is at the bottom, in the alveoli. The walls there have to be almost unimaginably thin.
This is the tennis court problem. You have to pack a massive surface area into a relatively small volume. The way the body does it is with the alveolar septum, the wall between the air and the blood. And that wall is built mostly of type I pneumocytes.
And what do they look like? How do they achieve that thinness?
Imagine taking a fried egg and stretching the egg white until it covers an entire dinner table. That's a type I cell. They are incredibly flat, plate-like cells that cover about 95% of the alveolar surface.
So they're just stripped down to the bare essentials.
Absolutely. They have almost no organelles. Their whole existence is just to be a minimal barrier for gas exchange.
But being that specialized and that thin must mean they're fragile. They can't divide, can they?
No, they are terminally differentiated.
Yeah.
If a type I cell gets damaged by a virus or a toxin and dies, it cannot divide to replace itself. You just have a hole in the tennis court.
Okay, so who fixes the hole?
That is the incredibly important job of the type 2 pneumocyte. These are, without a doubt, the unsung heroes of the lung.
So what do they do?
They're visually very different. They're cuboidal-like little blocks, and they're usually tucked away in the corners of the alveoli. And they have two superpowers. The first is that they synthesize surfactant.
Which is crucial for the mechanics of breathing.
Essential. Surfactant is a detergent. It breaks the surface tension of the thin layer of water lining the alveoli. Without it, the wet walls would stick together every time you exhaled, and the lung would just collapse.
Okay, so that's superpower number one. What's the second?
The second superpower is that type 2 cells are the stem cells of the alveolus. When those delicate type I cells are destroyed, the type 2 cells get the signal to proliferate. They divide, and then they differentiate into new type I cells to patch the wall and restore the barrier.
So the type 2 cell is both the maintenance crew and the reserve army.
Perfectly put. And patrolling this whole surface, you have the last major cell type, the alveolar macrophages.
The dust cells.
The dust cells, exactly. They aren't actually part of the wall. They're free-roaming. They crawl over the surface of the pneumocytes, basically eating any particle that made it past the mucociliary escalator. They are the frontline sentinels.
Before we move on from the normal anatomy, I want to ask about two structural quirks that Robbins points out that to me almost seem like design flaws. The first is the pores of Kohn.
Ah, yes. They are a feature that can become a bug in certain disease states. The pores of Kohn are literally just holes or perforations in the alveolar walls that connect adjacent alveoli.
So they're connecting neighboring grapes.
Correct. And in health, this is a great system. It allows for collateral ventilation. If a small bronchiole gets plugged with mucus, air can drift sideways through the pores to keep the alveoli behind that plug inflated.
But in sickness,
Say with a bacterial pneumonia, those pores become wide open doorways for the infection to spread. Bacteria and inflammatory fluid just pour through them, moving from alveolus to alveolus, spreading throughout the entire lobe. It's why lobar pneumonia can consolidate a whole lobe so quickly, it ignores the airway divisions and just spreads through the walls.
okay, that makes sense. And the second quirk was the fused basement membrane.
This is the thinness imperative taken to its absolute extreme. So normally an epithelial cell sits on its own basement membrane, and an endothelial cell in a capillary sits on its own. There's a little space between them.
But not in the lung.
Not in the thinnest parts of the gas exchange barrier. To save every possible nanometer of the fusion distance, Those two basement membranes actually fuse into a single layer.
Maximum efficiency.
Extreme efficiency. But it means there is zero buffer space. There's no wiggle room. If you get inflammation in that wall, there is nowhere for swelling to go without immediately and catastrophically disrupting gas exchange.
Which I think leads us directly into our first major pathology category. What happens when that incredibly delicate barrier fails on a massive scale? We're talking about acute lung injury and its most severe form, ARDS.
Acute respiratory distress syndrome. And it's really important to frame this correctly. ARDS is not a specific disease. You don't catch ARDS.
It's a pattern of reaction.
It's a pattern of reaction. It is the lungs' uniform stereotyped response to a catastrophic injury. And the trigger could be anything: sepsis, severe trauma with shock, inhaling toxic fumes, aspirating stomach acid, or a really bad viral pneumonia like influenza or COVID-19.
So the trigger can be completely different, but the lung's response is always the same.
Exactly the same. It's a cascading failure of the barrier that we just described. Robbins maps this out beautifully as a vicious cycle.
Okay, walk us through the steps. The injury happens. An insult to either the pneumocytes or the capillary endothelium. Then what?
The alveolar macrophages sense the damage, and they hit the panic button. They release a massive flood of pro-inflammatory cytokines, especially tuberous necrosis factor, or TNF, and interleukins.
This is the signal that there's a breach.
It's the flare going up. This chemical signal activates the endothelial cells and calls in the cavalry from the blood, specifically the neutrophils.
And neutrophils are effective, but messy.
Incredibly messy. They're the sledgehammers of the immune system. They stick to the capillaries, squeeze out into the alveolar space, and in the process, they degranulate. They release proteases that digest tissue and reactive oxygen species-free radicals.
So massive friendly fire.
Enormous friendly fire. And this chemical assault just shreds what's left of the delicate type I cells and the endothelium. The barrier, which was this finely tuned membrane, effectively becomes a sieve.
And fluid just pours through.
Protein-rich edema fluid from the blood floods into the air sacs. The patient is literally drowning from the inside.
But it's worse than just water, right?
Much worse. Because this protein-rich fluid mixes with the necrotic debris of all the dead epithelial cells. And this toxic slurry coagulates to form something called hyaline membranes.
This is a classic histological term. What does a hyaline membrane actually look like under the microscope, and what is it doing?
It looks like a thick, pink, waxy layer that's plastered onto the inside surface of the alveoli. Imagine trying to breathe if your lungs were coated on the inside with wax.
Oxygen can't get through.
It can't. It completely blocks gas diffusion. On top of that, the protein in the fluid deactivates any surfactant that's left. So the lungs become incredibly stiff and non-compliant. The patient goes into severe respiratory failure. This whole acute phase is what we call diffuse alveolar damage, or DAD.
Is it reversible? I mean, can the body scrape that wax off and heal?
The body tries, and this is the critical fork in the road for the patient. In the best-case scenario, the initial insult is controlled, the inflammation subsides, and macrophages come in to clean up the debris and digest the hyaline membranes.
And the type 2 cells get to work.
The type 2 cells proliferate like mad, cover the bare basement membrane, and then differentiate back into type I cells. The lung architecture can be restored.
And the worst-case scenario?
The repair signal gets crossed. Instead of orderly regeneration, the body activates fibroblasts. The fibroblasts migrate into that inflammatory mess and start laying down collagen. They start laying down scar tissue inside the alveolar walls and even in the air spaces.
So the lung becomes permanently fibrotic.
Yes, this is the organizing phase, and it can lead to permanent, irreversible scarring. So really, ARDS is a race against time. It's a race between regeneration and fibrosis.
That's a perfect way to frame it. Okay, let's shift gears from this kind of internal failure to an external attack. The invaders. Infectious diseases of the lung, starting with the big one, pneumonia.
Pneumonia is such a broad term. I think the best way to conceptualize it comes from Underwood, which defines it simply as consolidation.
Meaning solidification.
Exactly. It is the process of replacing the air in the lung sponge with something solid. In this case, inflammatory exudate fluid, immune cells, and fibrin. The lung literally becomes solid, like a piece of liver.
Now, for anyone studying this, the distinction between bacterial and viral pneumonia is absolutely critical. It's not just about the bug, it's about the geography of the battle.
That's a great way to put it. Bacterial pneumonia is typically an intra-alveolar process. The bacteria are living and multiplying out in the air spaces. So the immune response, which is mostly neutrophils, floods into those same air spaces to fight them.
Which creates the pus and fluid that fills the sacs.
Correct, and that explains the symptoms. That's why patients with bacterial pneumonia typically have a productive cough. They are physically coughing up the debris from the battlefield, which is located inside the airways and alveoli.
Okay, contrast that with a typical viral pneumonia.
Viruses are obligate intracellular parasites. They have to get inside our cells to replicate. So they infect the cells of the alveolar septal wall, the pneumocytes themselves.
So the fight isn't in the open space, it's in the walls.
It's in the walls. The immune response, which for viruses is mostly lymphocytes, not neutrophils, infiltrates the interstitium, the walls of the alveoli. We call this interstitial pneumonitis.
So the air spaces themselves might actually be relatively clear of fluid?
Relatively, yes. But the walls are swollen, inflamed, and thickened by all the immune cells. This creates a diffusion block for oxygen just as badly as fluid does, but without that massive pus-filled exudate. That's why viral pneumonia often presents with a dry, hacking cough. The irritation is there, but the buckets of pus aren't.
That's a really clear distinction. Let's go back to the classic bacterial progression. Lobar pneumonia. Robbins breaks this down into 4 stages that sound almost like something out of an art class, based on color.
It is a very chronological story of how the battle unfolds over about a week. Stage 1 is congestion. This is the first 24 hours the bacteria are just starting to multiply. The body responds with vasodilation, the capillaries engorge with blood to bring in troops, and protein-rich fluid starts to leak out. The lung becomes heavy, boggy, and red.
Then we move to stage 2, red hepatization.
Hepatization literally means liver-like. This is day 2 to 4. Now, the alveoli are completely packed solid. They are stuffed with neutrophils, with extravasated red blood cells, which give it the red color, and with strands of fibrin. The lobe is totally airless. If you were to handle it, it would look and feel exactly like a piece of raw liver.
Okay, so after red comes stage 3, gray hepatization.
This is around day 5 to 7. The tide of the battle is turning. The red blood cells that leaked out start to disintegrate and get broken down. The blood flow to the area decreases, but the fibrin and the dead and dying neutrophils, the pus, persist. So the color shifts from that vibrant red to a duller gray-brown. The lung is still solid, but the active, fiery inflammation is gone.
And finally, if all goes well, resolution.
This is the cleanup, starting around day 8. Enzymes produced by the body and the bacteria start to digest the exudate, turning it liquid. Macrophages move in to eat the debris, and the patient either coughs up the liquefied gunk or it's reabsorbed. Ideally, the underlying lung architecture is preserved and it returns to normal.
But sometimes the tissue itself doesn't survive the battle.
Right. If the infection is particularly virulent or the host is compromised, you can get significant tissue necrosis. This is what leads to a lung abscess.
The cavity.
A cavity. It's defined as localized suppurative necrosis. The lung tissue itself dies and liquefies, leaving a hole filled with pus and foul-smelling, rotting debris. We sometimes call it gangrene of the lung.
And that's often associated with aspiration, right? Inhaling stomach contents.
That's the most common cause. People who are unconscious from alcohol, drugs, a seizure, a stroke, they lose their gag reflex, they vomit and inhale that acidic material mixed with anaerobic gut bacteria. That combination is incredibly destructive and just chews a hole in the lung.
Let's shift from that kind of acute, fiery battle to more of a slow burn. Tuberculosis. TB just feels different. It's not a rapid war like pneumococcal pneumonia. It's a lifelong siege.
It's a fascinating immunological standoff. The body recognizes very quickly that it cannot easily kill Mycobacterium tuberculosis. The bug has this incredibly waxy cell wall that resists being digested by macrophages.
So the immune system can't win outright.
It can't, so it switches strategies from kill to contain. This is the classic type IV hypersensitivity reaction. Key cells are the generals. They issue orders to the macrophages, telling them to change their form.
How so?
They transform into these epithelioid cells. They get very large and pink, and they start to look like epithelial cells. Then they fuse together to form multinucleated giant cells. And these modified macrophages build a literal wall around the bacteria. This structure is the granuloma.
It's a prison for the bacteria, but inside the prison, things are not so great.
No. The center of the granuloma undergoes a specific type of necrosis called caseous necrosis. Caseous means cheese-like. It's a soft, white, crumbly material that looks a bit like cottage cheese. It's a mix of dead macrophages and the lipid-rich debris from the dead bacteria.
Now, we absolutely have to clarify the timeline here. The difference between primary and secondary TB, this confuses a lot of people.
It's crucial. Think of it as the first encounter versus the jailbreak. Primary TB is what happens when you, as an immunologically naive person, first inhale the bug. It usually lodges in the mid-zone of the lung where airflow is good.
And the body forms a granuloma.
It forms a small subpleural granuloma. We call that the Gone focus. Yeah. If the bacteria then travel through the lymphatics to the nearby hilar lymph node and form a granuloma there as well, the combination of the lung lesion plus the nodal lesion is called a Gone complex.
And for most healthy people, that's pretty much the end of the story, right?
In about 95% of healthy people, yes. The immune system contains it. The Gone complex heals, it scars down, it often calcifies, and the bacteria go dormant. They aren't dead, but they are sleeping inside that calcified scar. Until your immune system takes a hit.
Yeah.
Decades later, maybe you get older, maybe you develop diabetes, maybe you need chemotherapy for a cancer, maybe you contract HIV. Something weakens your T-cell surveillance.
And the bacteria wake up.
The bacteria wake up. This is secondary, or reactivation, TB, the jailbreak.
And the location changes, which is a key feature.
It moves. It almost always reactivates in the apex, the very top of the lung.
And why there? What's so special about the apex?
Oxygen. M. tuberculosis is a strict aerobe. It loves oxygen. And because of gravity, the apex of the lung has the highest oxygen tension. Ventilation is great up there, but blood flow or perfusion is relatively lower. So it's this perfect high oxygen, low immune surveillance environment for the bug to thrive.
And secondary TB is far more destructive than primary.
Much more so. The immune system is already primed, so the hypersensitivity reaction is massive and vigorous. You get large destructive granulomas that tend to undergo extensive caseation, and then they cavitate.
They turn to liquid and form a hole.
They liquefy and erode into a bronchus. And once that happens, the patient starts coughing up infectious sputum full of live bacteria. They become contagious.
And if it erodes into a blood vessel instead of an airway...
That's a systemic catastrophe.
Yeah.
That's miliary TB. The bacteria are showered through the bloodstream like millions of tiny millet seeds, which is where the name comes from. You get tiny granulomas dotting the liver, spleen, kidneys, bone marrow, brain, everywhere. It's usually fatal if not treated.
Okay, that's a lot on infection. Let's move from invaders to mechanics. We categorize most chronic lung diseases into two massive opposing buckets, obstructive and restrictive. Let's start with obstructive disease. This is all about the struggle to get air out.
That's the perfect summary. Imagine trying to breathe out forcefully through one of those tiny coffee-stirring straws. You can suck air in okay, but pushing it back out against that resistance is slow and exhausting. That is the core experience of obstructive disease.
And clinically, how do we measure that resistance?
We use spirometry. We have the patient take the deepest breath they can and then blast it out as hard and fast as possible. We measure the FEV1, the forced expiratory volume, in 1 second. In obstructive disease, the FEV1 just collapses. It's dramatically reduced.
So the speed of airflow is gone.
It's gone. The total lung capacity might be normal or even high because air gets trapped, but you can't get it out quickly. The key metric is the FEV1-FVC ratio. That ratio drops significantly.
The big umbrella term everyone knows here is COPD, chronic obstructive pulmonary disease. But Robbins is very clear that we need to split this into two distinct, though often coexisting, pathologies: emphysema and chronic bronchitis.
Yes, it's vital to separate them conceptually, at least to begin with. Emphysema is an anatomical diagnosis based on structural changes. Chronic bronchitis is a clinical diagnosis based on symptoms.
Let's tackle emphysema first. We used the grape cluster analogy for the acinus earlier. Emphysema is the destruction of those grapes.
That's it. The formal definition is the irreversible enlargement of the air spaces distal to the terminal bronchiole, accompanied by the destruction of the alveolar walls, and critically, without obvious fibrosis.
So you're not scarring the lung, you're dissolving it.
You're dissolving it.
Wow.
Think of the lung as a sponge with millions of tiny holes. Emphysema eats away the walls between the holes, turning them into a few large, floppy, useless sacs.
Which means less surface area for gas exchange, obviously. But why does the air get trapped? Why is it an obstructive disease?
Because you've lost elastic recoil. The healthy alveolar walls are full of elastic fibers. These fibers act like the radiating guy ropes of a tent, tethering the small bronchioles and holding them open from the outside.
Okay.
So when you exhale normally, it's a passive process. That elastic recoil just gently squeezes the air out. But in emphysema, you've cut the tethers. The walls are gone.
So when you try to force air out...
The small airways, now unsupported, just collapse. They flop shut, trapping the air behind them. The harder you push, the tighter they close. It's a dynamic collapse, a check valve effect.
What's driving this destruction? What's dissolving the walls?
It's a chemical imbalance. The classic protease-to-antiprotease hypothesis. Your lungs naturally have neutrophils that hang around, and they contain powerful enzymes like elastase, which, as the name implies, breaks down elastin.
But normally that's kept in check.
Normally, yes. Your liver produces a protein called alpha-1 antitrypsin, or A1AT, which circulates in the blood, enters the lung, and acts as a shield. It neutralizes the elastase. It's a beautiful balance.
But smoking ruins it.
Smoking completely upends the balance in two ways. First, it causes massive inflammation, recruiting millions more neutrophils and macrophages to the lung, which means you're dumping tons more elastase into the system. And second, the oxidants in cigarette smoke directly inhibit the A1AT shield that's already there.
More enzyme, less shield.
The scale tips dramatically. The elastase runs wild and starts digesting your lung tissue.
And this same mechanism explains the rare genetic form of the disease, too.
Exactly. Some people are born with a genetic deficiency of A1AT. They simply don't make the shield. So even without smoking, the small, normal amount of elastase from routine immune activity slowly but surely eats their lungs away over their lifetime.
Now, Robbins makes a big deal about the anatomical pattern of the damage, distinguishing the smoking-related type from the genetic type.
Yes, this is a classic exam question. Smokers typically get centriacinar emphysema. The smoke particles are heaviest in the center of the lobule around the respiratory bronchioles. So the destruction starts there in the center and spares the distal alveoli, at least initially.
And it affects the upper lobes more.
Right, because smoke rises. In contrast, A1AT deficiency causes panacenar emphysema. The enzyme imbalance is in the blood, so it affects the entire sinus or panacinus uniformly from start to finish. And for reasons that are less clear, it tends to be most severe in the lower lobes.
Okay, now paint the clinical picture for us. The classic archetype of the patient with pure emphysema, the pink puffer.
Right. This person's main problem is getting air out against those collapsing airways. So they work incredibly hard to exhale. They develop this characteristic pursed lip breathing, almost like they're whistling, which creates back pressure to stent the airways open.
And why pink?
They're pink because they're hyperventilating so much to maintain their oxygen levels that they don't become cyanotic until the very end stages. They keep their blood gases surprisingly normal for a long time, but the work of breathing is immense. They are burning thousands of calories a day just moving their chest.
So they become very thin.
They're often skeletal, cachectic, with a barrel chest from all the trapped air. They're puffing, but they're pink.
Now let's contrast that sharply with the other side of the COPD coin. Chronic bronchitis. The blue bloater.
A completely different beast. Remember, the definition here is clinical. A productive cough with sputum for at least 3 months a year for 2 consecutive years. The pathology is not in the alveoli, it's in the airways, the bronchi.
It's the mucus factory again.
Gone into overdrive. The primary lesion is massive hyperplasia of the submucosal glands in the large airways. Robbins talks about measuring the Reed index, the ratio of the gland layer thickness to the total wall thickness. In bronchitis, the glands just take over.
And you get more goblet cells, too.
You get goblet cell metaplasia in the small airways, where they shouldn't be. So the pipes are physically clogged with thick, tenacious mucus.
So it's an obstruction from within.
Exactly. And because the airways are plugged, you get a severe ventilation-perfusion mismatch. Blood flows past unventilated alveoli. So these patients can't maintain their oxygen levels. They retain CO2, becoming hypercapnic, and their oxygen saturation drops. That's the blue, the cyanosis.
And the bloater.
The chronic low oxygen hypoxia causes the pulmonary arteries to constrict. This is called hypoxic vasoconstriction. This puts a massive strain on the right side of the heart, which has to pump against this high pressure. Eventually, the right heart fails. We call this cor pulmonar.
And heart failure leads to fluid retention.
Right-sided heart failure leads to fluid backing up in the systemic circulation. They get peripheral edema, swollen legs, a bloated appearance. They're often overweight, cyanotic, and struggling, hence blue bloater.
Before we leave obstructive diseases, we have to touch on asthma. What makes it different from COPD?
The single most important word is reversible. Asthma is not primarily a disease of structural destruction. It's a disease of hyperreactive airways. The immune system overreacts to a trigger pollen, cold air, exercise, and it causes 2 things: inflammation and intense bronchospasm.
The smooth muscles in the airway walls clamp down.
They clamp down hard. And if you look at the pathology, the inflammation is very different from COPD. The hallmark cell is the eosinophil, and in the sputum you can find characteristic microscopic findings like Charcot-Leyden crystals, which are crystals made from eosinophil proteins, and Kirschmann spirals, which are twisted casts of mucus plugs.
But over time, if it's poorly controlled, it can become less reversible, right?
Yes. This is a critical point. We call it airway remodeling. After decades of recurrent inflammation, you get structural changes. The smooth muscle hypertrophies, the basement membrane thickens, the mucous glands get bigger. It starts to look and act more like a fixed chronic obstruction.
Okay, let's flip the script completely. We've done getting air out. Now for Section 5, the restrictive diseases, the struggle to get air in.
If obstructive disease is like breathing through a straw, restrictive disease is like trying to breathe while wearing a suit of armor that's 2 sizes too small. The lungs themselves are stiff. Their compliance is gone.
So you simply can't fill them up. You can't take a deep breath.
Exactly. The total lung capacity, or TLC, is reduced. That's the hallmark. But, and this is the key differentiator, the airways themselves are usually open. In fact, because the surrounding lung tissue is so stiff and fibrotic, it often pulls the airways open even wider.
So the airflow is actually fine.
The airflow is great. Whatever small volume of air you do get in, you can blast out very fast. The recoil is high because the lung is so stiff. So the FEV1 and FVC are both reduced, but their ratio, the FEV1-FVC ratio, is normal or even slightly increased.
And the prototype for this category, the one everyone thinks of, is idiopathic pulmonary fibrosis, or IPF.
IPF is a truly devastating diagnosis. It's a progressive, relentless scarring of the lung interstitium. And idiopathic means we don't know the specific trigger. But the current thinking on the mechanism is that it's a disease of aberrant repair.
The type 2 cells are involved again.
It seems so. The hypothesis is that there are repeated subclinical microinjuries to the alveolar epithelium. This initiates a repair response from the type 2 cells, but for some reason, maybe genetic predisposition, maybe cellular aging, the repair process goes wrong. Instead of regenerating the epithelium, the cells release profibrotic factors like TGF-beta.
Which tells the fibroblasts to make scar tissue.
Exactly. It becomes a scarring machine that you can't turn off. It just keeps laying down more and more collagen in the alveolar walls.
Now, Robbins highlights a very specific and crucial pattern that you see under the microscope. The UIP pattern, usual interstitial pneumonia.
This is the histological hallmark of IPF. And the key feature of UIP is something called temporal heterogeneity.
Sounds like time travel.
In a way, it is. When you look at a biopsy slide, you can see different stages of the disease process happening all at the same time, right next to each other. You'll see areas of old, dense acellular collagen. Those are ancient scars. Right next to that, you'll see these things called fibroblastic foci, which are collections of active fibroblasts laying down fresh, new scar tissue. And then right next to that, you might see an area of completely normal lung.
It's a patchwork of destruction over time, all visible in one snapshot.
Precisely. And as this process continues, the architecture completely collapses, leading to the end-stage appearance of honeycombing.
What does that look like?
The relentless fibrosis pulls and distorts the lung, collapsing the alveolar walls and creating these large cystic air spaces that are lined by hyperplastic type 2 cells. On a CT scan of the chest, it looks exactly like a honeycomb.
And Underwood mentions a very specific sound you hear with the stethoscope.
Yes. Velcro crackles. Fine, dry crackles, usually at the end of inspiration. It's thought to be the sound of those stiff, fibrotic distal air sacs finally snapping open against the resistance of the scar tissue.
Of course, not all fibrosis is a mystery. Sometimes we know exactly what caused it. This brings us to the pneumoconiosis, the occupational dust diseases.
Right. This is the environment attacking the lung again. As we said before, our alveolar macrophages are fantastic at eating and digesting organic things like bacteria. They are terrible at eating and digesting inorganic mineral dusts.
It's like trying to digest a shard of glass.
It is. Take silicosis. From inhaling silica dust, sandblasters, miners, stone cutters, you inhale the silica crystals. The macrophage in your alveolus dutifully eats one, but it can't break it down. The silica crystal is toxic to the inside of the macrophage, and it ruptures the phagolysosome,
Killing the macrophage from the inside.
killing it from the inside. The macrophage bursts, releasing its inflammatory guts and the silica particle, which is then eaten by another macrophage. And the cycle repeats. This creates a chronic, self-perpetuating inflammatory fire that stimulates fibroblasts to form these hard, whorled, collagenous nodules in the lung.
And there's a deadly synergy here with another disease.
A very deadly one. Silica directly impairs the macrophage's ability to kill intracellular bacteria. Specifically, it cripples their ability to kill tuberculosis. So patients with silicosis are at a massively increased risk of contracting and dying from TB.
Then there's the most infamous dust of all, asbestos.
Asbestos is notorious. The fibers are sharp and needle-like. When inhaled, they cause a diffuse interstitial fibrosis that can look a lot like IPF. Microscopically, you find the classic asbestos bodies.
What are those?
They're the asbestos fiber that's been coated by the body in iron and protein in an attempt to wall it off. They look like little golden brown beaded rods under the microscope.
And the cancer risk is the headline everyone knows, specifically mesothelioma.
True, but there's a very important nuance here. Asbestos exposure is the only major cause of mesothelioma, which is the rare and terrible cancer of the pleura, the lining of the lung. However, mesothelioma is still quite rare. The most common cancer that an asbestos worker will get is actually just regular lung carcinoma, adenocarcinoma, or squamous cell carcinoma.
And if you happen to smoke and work with asbestos?
The risk is not additive, it's multiplicative. It's a synergistic effect. If smoking increases your risk of lung cancer by, say, 10-fold, and asbestos exposure increases it 5-fold, having both doesn't make your risk 15-fold, it makes it 55-fold. It is an almost certain death sentence.
That's staggering. Okay, let's briefly touch on a couple of other restrictive patterns before we move on. Sarcoidosis.
Sarcoidosis is a systemic disease of unknown cause, characterized by non-caseating granulomas.
Non-caseating, so no cheese-like necrosis.
Correct. They are tight, well-formed collections of epithelioid macrophages, but without the central necrosis you see in TB. It's a diagnosis of exclusion. You have to rule everything else out first.
All right, let's move to the last major section. The lung isn't just a bag of air, it's a massive vascular bed. Let's talk about vascular pathology.
It's a huge part of it. The entire cardiac output, every drop of blood goes through the lungs with every circuit. And the big killer in this category is pulmonary embolism, or PE.
A blood clot in the lung? Where does it usually come from?
Over 95% of them originate in the deep veins of the legs, a DVT. For whatever reason, stasis from a long flight, hypercoagulability, a clot forms in the leg. A piece of it breaks off, rides the vena cava up to the heart, passes through the right atrium and ventricle, and gets launched into the pulmonary artery tree where it gets stuck.
Now, does that cause an infarct? Does the lung tissue downstream of the clot die like heart tissue does in a heart attack?
Surprisingly, usually not. And this is thanks to a brilliant biological failsafe. The lung has a dual blood supply.
Explain what that means.
The main blood supply is the pulmonary artery system, which brings deoxygenated blood from the right heart for gas exchange. But the lung tissue itself, the bronchi, the blood vessels, the interstitium, needs its own oxygenated blood supply to live. It gets that from the bronchial arteries, which are small vessels that branch directly off the aorta.
So they're getting systemic, high-pressure, oxygenated blood.
Exactly. So if a PE blocks a branch of the pulmonary artery, the bronchial circulation can usually ramp up its flow and keep the lung tissue alive. You'll be breathless because you've lost gas exchange surface, but the tissue itself doesn't necrose.
So you get symptoms, but not an infarct.
Unless the patient is already in circulatory failure. If they have severe congestive heart failure, for example, the pump is weak and the bronchial supply can't compensate, then, and really only then, do you get a classic wedge-shaped hemorrhagic infarct in the lung.
And finally, we have to touch on the ultimate failure of growth regulation, lung cancer.
The leading cause of cancer death in both men and women. And it is overwhelmingly an environmental disease, driven by the cumulative injury from everything we inhale. We broadly classify it into two major groups, small cell and non-small cell carcinoma.
And why is that the most important split?
Because it dictates therapy completely. Small cell lung carcinoma is a high-grade neuroendocrine tumor. It's incredibly aggressive. By the time you find it, it has almost always already metastasized. You can't cut it out. The only treatment is chemotherapy and radiation.
And non-small cell.
There's a broader category that includes adenocarcinoma, which is now the most common type, and squamous cell carcinoma. These tend to grow more slowly and stay localized for longer. If you catch them early enough, surgery is a potential cure.
Now, Underwood mentions that the symptoms, cough, weight loss, chest pain, often come very late. But sometimes the first sign is something really strange, like a hormonal problem.
Yes, the perineoplastic syndromes. These are particularly famous with small cell. Remember we said it's a neuroendocrine tumor. It arises from those neuroendocrine cells in the bronchial lining. So the tumor can retain the ability to secrete hormones.
Like what?
It can produce ACTH, the hormone that stimulates cortisol, and give the patient Cushing's syndrome. It can produce ADH, antidiuretic hormone, and cause the patient's sodium levels to crash. It's a tumor that's acting like a rogue, unregulated endocrine gland.
Wow, we have covered a massive amount of ground here, from the microscopic architecture of the type 2 cell all the way to the honeycomb lung of end-stage fibrosis. If we had to synthesize all of this for the listener, what's the big picture takeaway?
I think the single recurring theme is the inherent fragility of the interface. The lung is exquisitely designed for one primary purpose, gas exchange. And to do that, it has to sacrifice thickness, it has to sacrifice robust protection, it is living on a knife's edge, relying on this delicate balance of airflow, blood flow, defense, and repair.
And every disease we've talked about is just the tipping of that balance in one direction or another.
Exactly. Whether it's the waxy hyaline membrane of ARDS creating a diffusion block, or the dissolution of the walls and emphysema wrecking the mechanics, or the relentless scarring and fibrosis stiffening the whole structure. It all comes back to that central, unavoidable engineering conflict. Thin enough to breathe, strong enough to survive.
It really makes you appreciate the simple, unconscious act of taking a breath in a whole new way.
It is a high-wire act that our bodies perform perfectly, billions of times over a lifetime.
We will leave you with that thought to mull over. And please, remember what we said at the start. This deep dive was the map. Now you need to go read the territory. Open Robbins. Open Underwood. Look at the pictures. You really need to see the histology of a granuloma, see the hyaline membranes to make it all stick.
Absolutely. The images are key.
Thanks for listening. We'll see you in the next deep dive.
Goodbye.